Denny's spinal adaptation syndrome was a theory that came out of work from a physician named Ernst Denny out of Germany. And some important parts that came out of this that kind of, again, influences the way we do a lot of our treatments. When someone has an injury, the pain impulses, those sensory afferent impulses from damaged tissue, alter CNS excitation at the spinal cord. Essentially what it does is it causes a decrease in response to volitional stimuli and basically an increase in involuntary muscle action. So the increased involuntary muscle action will actually inhibit motor function or the muscle activity in somebody that's injured. So the idea here is to try to reestablish central control. By reestablishing central control, you're going to limit somebody's disability and pain that they're experiencing from the injury. And this is kind of what he was getting into with some of his work, was that he was finding out that, keeping patients immobilized for long periods of time was actually, again, not working out well for the patients. So the idea here is if you can get somebody moving, now obviously you have to take into consideration the repair state of the tissue, but as soon as you can get somebody moving, you're going to limit the impact that this afferent activity has on the spinal cord. In other words, if you could somehow send and get the person doing activity and reestablishing motor control, the less of an effect these impulses are going to have on the individual patients. So that leads to this whole concept of, again, reestablishing central control will limit that motor inhibition. So essentially what you're trying to do is reset the system and get rid of kind of the lingering effects of pain. In other words, it'll be a situation where the person ends up having greater disability and more limitations because of the individual pain they're experiencing. That there's a really good case of this kind of showing practically how this works. And when you read the case, you may have even seen this in some of your patients at your clinicals, or if you're an athlete and you've been injured, it's a situation you may have seen yourself. So I'd suggest to kind of see this, look on page 166 and read the short case study. It kind of will put this in perspective as far as the importance of resetting central control. In finding ways to kind of deal with some of the issues associated with pain, again, from all these things we talked about, the spinal adaptation syndrome, central control, again, pain is something that goes beyond just traumatized or injured tissue. So, again, bringing up the concept that, again, you have your traumatized tissue, you have pain, you're also going to have inhibited motor function. Again, and some of this will come from these concepts that we just talked about with the spinal adaptation syndrome. This involuntary muscle action that happens will actually inhibit voluntary muscle control that you want to do. So the faster you can reestablish that central control, the easier you will be able to prevent this inhibition, and essentially you'll be able to get the person functional a lot faster. Again, you still have to operate within the confines of healing tissue. If you're trying to push somebody and you're pushing them to the point in certain circumstances where they're doing complex activities and having a good amount of pain, that's not good either. That's actually going to basically encourage the process of inhibition, which could set them up for possible further injury. So, the equivalence would be as if you had somebody with a MCL sprain and you were trying to have them doing running and cutting activities, but during the running and cutting activities they're having a lot of pain. You don't want that to happen, okay? That's pushing them too fast, and basically that's going to create more of an inhibition of motor activity that's going to possibly predispose them to injury. but at the same time, on the other end, prolonged inactivity is actually going to continue to lead to inhibition as well. So that's why it's important when you're dealing with this, get patients moving as quick as you can. It's kind of like the take-home point. Get patients moving as quick as you can, but you still have to take into consideration their response to pain. And if complex functional activities in particular are causing pain, you have to find some ways to modify the activity, or else you're going to basically encourage this inhibited motor function. Looking at all these concepts in regards to orthopedic pain. So looking at sources of orthopedic pain. So think to yourself now, what are sources of orthopedic pain? So you look at the pictures and the examples here. Obviously some different things that are happening. You're going to have damaged tissue or injured tissue, which is going to cause chemical mediator release. You have the formation of edema, which is going to put pressure in the area, put pressure on nerve endings. You're going to have situations where injured tissue is stretched, and basically any type of normal activity in a tissue that gets sensitized from injury. So for instance, just something as simple, if you look at that ankle in the picture, if that person was to walk, which would be considered a normal activity for that person, they're probably going to be in some pain. So that normal activity is going to cause that tissue just to be overly sensitive. So those are some of our general sources of our structural orthopedic pain that we experience. Our sources of injury pain are these concepts. We kind of talked about this before earlier on in the discussion, but we have our nociceptive pain. Again, most of our acute injuries, we have our sensory impulses that come about through the damaged tissue and all of the chemical mediators. Again, a lot of the sources of pain that we had talked about on the previous slide. Your neuropathic pain, again, is usually going to be caused by actual damage to the nerve fibers themselves. Again, sometimes this can show up in a lot of your book describes it as illogical ways, and you see this a lot, particularly with your chronic injury. So with neuropathic pain, there could be some unique presentations. You just kind of have to look at what is actually causing it. So for instance, if someone has surgery that involves neural tissue, phantom limb pain actually falls within the classification of this. Remember, we talked about phantom limb pain earlier, basically where someone who's had an amputation experiences pain in a limb that's not there. So it kind of could have some unique presentations with neuropathic pain. Our learned pain, again, that's going to come about from our pain memories and some of the different things with that. Actually, when you look at the application of Denny spinal adaptation syndrome, that's an example where pain can become a learned pain situation, where somebody is highly inactive, and again, they get all that inhibited motor activity, and involuntary muscle action could cause a situation where the individual develops a high sensitivity to learned pain. And then our idiopathic pain, again, that just basically means there's no identifiable pathology associated with it. So it's not something where you could locate a direct specific cause. Now, the placebo effect, this is probably something you've heard of before, even before reading this chapter. It's basically when a patient has a positive view of a treatment, they actually start to get benefits from it, even though maybe there's no physical change happening. So it's when there's a medically inactive substance produces a positive effect. And the common examples of this that you see is the sugar pill. In other words, what they do is in a lot of, if they want to study like the effects of a medication, they may put half the subjects on the actual medication, the other half on a sugar pill, to see if the benefits that everyone gets are truly from the medication, or if both groups kind of have equal benefits, then there's a placebo effect with the medication. It might not be the actual medication that's working. So there's obvious psychological factors with this. So, obviously patient expectations of getting better and even the clinician's expectations of the patient getting better are both things that will kind of bring about changes or benefits from this treatment. The other thing to realize, though, is that it's not a non-treatment. The placebo effect isn't necessarily a bad thing, particularly as it relates to pain. So in regards to pain, they've actually found through brain mapping with MRI that the neurotransmitter release, there's neurological reactions that are actually happening that could change how the person's interpreting pain. So, in other words, it can actually affect somebody's descending pain control. So, the placebo effect is certainly something that can be utilized, again, as long as it's done in a responsible manner and you're not basically trying to promote fake treatments. But at the same time, if a patient is getting better, they're experiencing a decrease in pain, as long as you're still progressing them responsibly for the rest of their treatment, it can be something that you utilize, and you may be utilizing it and don't even realize it. Not that you're even doing it intentionally, but it can be something that can help somebody in decreasing their pain. Some different pain relief methods we utilize, and there's various classifications. When you're strictly looking at techniques, we have two different techniques for removing pain. We have indirect methods and we have direct methods. Indirect methods remove a cause of pain. So if someone has swelling, if somebody has muscle spasm, by reducing that swelling or reducing that muscle spasm, we relieve pain. That's considered an indirect method. Your direct methods deal with pain itself, so they directly address pain. So take, for instance, applying a transcutaneous electrical nerve stimulation. That's obviously going to be a direct method of pain relief, because we know that using TENS in that fashion will, if we're using it for level 1 gait control pain, that's directly dealing with pain, versus, say, using elevation for an ankle sprain to reduce swelling, which would be obviously putting pressure on nerve endings, will help bring down pain as well. So indirect deals with removing a cause of pain, direct deals with eliminating pain itself. So looking at some of the methods we use, exercise is, again, a very important part of all this. Again, all these modalities we talk about are great, but the modalities are really utilized to try and get somebody to exercise, because that's really, in the end, what's going to make them better. The key here is that you need to make sure that you're doing things relatively pain-free. Again, going back to those concepts of central control, going back to the concepts of Denny spinal adaptation syndrome, if an exercise is going to cause too much pain, in other words, if you're stressing the tissue too much, it's going to cause inhibited motor action, which could possibly cause someone to re-injure themselves, or even possibly worse, give themselves an injury that was worse than the ones to start with. So it has to be controlled exercise. If there's some mild pain with it, that's okay. If it's getting to the point where the pain is starting to increase, almost get to the point of the original injury, you don't want that. So good controlled exercise is going to be an important part of that. Your counter irritants are substances or modalities that basically irritate the skin, and in some situations will actually call mild skin inflammation. That's essentially what a lot of your topical analgesic balms, your Flexol, your Biofreeze, your Tiger Balm, all of those things are counter irritants. What they basically do is they irritate the nerve endings in the skin, again, basically causing a gating response. In other words, the sensation that you experience from the, again, icy hot or the Flexol, the Bengay, whatever it is, actually causes your brain to turn its attention from the pain to that. Okay, so again, they're useful. They don't do what a lot of the commercials say they do. They don't produce any heat or anything like that. It's just basically a topical effect causing the nerve endings to produce a gating response. Some of the modalities we use essentially do the same thing. If you put an ice bag on somebody, technically that's also a counter irritant as well, as far as from the pain relief aspect goes. And there's some other examples in your book of some different counter irritants that get used. Looking at other pain relief methods, we have our thermotherapy. So, the benefits of heat, some of which we've talked about when we discussed superficial heat: increased blood flow, promotion of relaxation, reduce muscle spasm. Obviously, if muscle spasms are relaxed, the pressure on nociceptors is going to be decreased. Also, the combination of the gate theory, which some believe are applicable as far as its application of thermotherapy, and also the decrease in response rate of nerves, particularly your gamma motor nerves. So the gamma motor nerves are potentially going to be a cause of pain associated with this. So they believe that by reducing the input with superficial heat, that will help bring down pain as well. Electrotherapy can reduce pain in one of three ways, depending upon the type of electrical stimulation that gets utilized. Reducing muscle spasm is one way, releasing endogenous opiates, and stimulating non-painful nerves, or your A beta fibers. So if you go back to our 3 levels of pain relief, you could go back and actually apply each one of those to one of those 3 levels, okay, depending upon how the pain is actually reduced. Cryotherapy, most specifically in application to more acute and or subacute pain, if it limits activity. Again, in comparing and contrasting cryotherapy and thermotherapy or heat is going to be beneficial, particularly as it relates to more general soreness, dull, aching type pain, whereas cryotherapy is going to be more beneficial for your acute pain or possibly to facilitate exercise. Immobilization can be utilized as well. If tissue needs to be immobilized to heal, or if moving it is going to cause further damage and more pain, obviously in that situation we need immobilization. However, again, it's that fine balance. By immobilizing for too long, you're going to possibly cause further disability. Again, those, getting back to the whole spinal adaptation syndrome and resetting central control is, concepts you have to be looking at when you're looking to immobilize somebody. And again, therapeutic exercise, very beneficial from the standpoint of stimulating lymphatic flow. Obviously, that's going to be beneficial in reducing swelling. So with therapeutic exercise, again, it has to be relatively pain-free. Okay, some mild discomfort is acceptable, but if too much is being done, then you're going to possibly, again, cause damage to the tissue and cause inappropriate motor activity. That involuntary muscle control is going to be affected if the therapeutic exercise is done in a painful manner. And we talked about the application of counter irritants, again, most specifically your analgesic balms. And the analgesic balms will contain 1 of 2 ingredients. They'll either contain menthol or methyl salicylate, are the 2 common ingredients found in most of your different counter irritants. Again, your examples, your Biofreeze, your Flexol, again, they just basically irritate the superficial nerve endings, which will cause a gating response. And, again, the psychological aspect, remember, there's going to be other things beyond structural damage that impacts pain. So, some different things that could go along with the psychological aspect, setting goals and expectations. There's biofeedback can be utilized with this, different cognitive strategies. So, attention modulation can distract the patient from the pain. Even things such as meditation, just in general having a positive attitude, appropriate social interaction are all psychological things that could kind of help as they're kind of going through this process of trying to relieve pain and trying not to have pain be an issue that kind of gets them stuck during their rehabilitation. Now, looking at some ways of monitoring and assessing pain. So, just some different things you could do, and I'm just showing some examples here. The most common one we use are our pain scales. So, you see here 0 being nothing at all. I know some people use the 1 to 10. I think 0 to 10 is a little better to use just because it gives people something to go off of. So, obviously, 0 is they're healthy, there's no pain. So I think to put it in perspective from that manner, it may make it a little easier to kind of quantify somebody's pain. So your common 0 to 10 pain scale. There's also other types of questionnaires. I'm just going to show you some examples so you can kind of get an idea as far as how different pain scales are used. And this just kind of somewhat quantifies, again, what's one person's 1 could be another person's 3, just even as far as the pain scale concerns, but at least everything's relative to that individual so you can see whether or not they're actually getting better. This is the visual analog scale. So if you look at this, it just kind of goes through. It's just something that they could scale. So if you look on the bottom, you see like the line, so the visual analog scale for pain, visual analog scale for pain relief. So no pain, severe pain, the patient would basically mark somewhere on the line where they fall as far as their actual pain is concerned. And on the bottom, they have the visual analog scale for pain relief. They could put a line, to no pain relief or complete pain relief to basically note how well they're actually progressing. Other examples of this you sometimes see they have like different kinds of they have a smiley face on one end, and all the way on the other end they have a face where there's a frown and the person and the face is crying. That's another example of sometimes how this is used, and the people will rate their pain based upon the actual pictures of the faces as well. This is an example of something that is slightly more involved. This is a McGill questionnaire. So the McGill questionnaire actually gets into all different types of descriptors of pain. So if you kind of look on here, it might be a little hard to see depending upon how big your screen is when you're looking at this. But first of all, you have the body where you actually go and they, for instance, they'll recommend you circle your area of greatest pain. And then there's all the different descriptors of pain lined up here that you can talk about and rate your different pain. So this just kind of shows you, again, it's kind of a continuing going from the simplest being just the numerical pain scale to something as complicated as the McGill Pain Questionnaire. So just some different examples of ways that you can quantify pain depending upon how you want to go about the process. So here's just a summary of your learning outcomes. So, we had a lot in here, but really, if you think about a lot of what we discussed, we kind of were going back sometimes and reviewing things. And a lot of this does, if you really kind of break down and understand the concepts to how we perceive pain, you see that a lot of these things are related back to each other. The concept of learned pain, the resetting central control, and how getting people to do activity, just itself doing that will sometimes limit pain and disability from the injury itself as well. So this is kind of a summary of the different points that you need to know as far as this topic is concerned.